rib fracture, a rib can puncture the lung and it could happen. Real short of breath, chest pain, sharp pain on inhalation. Percussion. We want to hear resonance, a normal sound over the lungs. If you were to puff out your cheeks and tap your finger against your cheek, that's what resonance sounds like.
Is it a hollow?
We have, yeah, it's going to be hollow sounding over the lung fields, but we have a lot of ribs to worry about, so you have to actually go in between the ribs in order to percuss, in order to hear the resonance. A flat sound is going to indicate bone, so you're going to be, you possibly are on the rib, or you can be over fluid, like a pleural effusion. A dull sound is like more of a thud-like sound. And that's going to be over a dense area like the heart and the liver, or a mass. Dull can also be pneumonia and or atelectasis from pneumonia, the air sacs are filled. Timpani is more of a hollow, what you're going to hear over something hollow. It's going to be drum-like. So a large pneumothorax would be timpani. Hyperresonance would be a pneumothorax also, emphysema, asthma. Too much air with hyperresonance. Use your forefinger, middle finger to tap against your first metacarpal on the opposite hand. We don't do percussion anymore because we have x-rays and CAT scans and everything else in the world that very seldomly you see. Maybe an old school doc who's about 90, 95 might do it. I don't think you'll ever see a nurse practitioner doing that. So auscultation, use the diaphragm of the stethoscope, the larger part of the two parts. We want to make sure that everything's symmetrical. Now, anteriorly, we're going to listen 6 to 10 spots, at least 6, but up to 10. You want to start above the clavicle and work your way down. Anteriorly, posteriorly, you're going to do like 14 to 18 spots. Go left to right or right to left and make sure that the lung field is symmetrical and we hear the same things on both sides. The normal breath sounds we're going to hear are bronchial, bronchiovesicular, and vesicular. Bronchials over the large airways. They're loud and tubular sounding. And we're going to hear them like at the second and third intercostal spaces, like right here. Bronchovesicular are more mid-chest, anteriorly and posteriorly. On inspiration and expiration. And vesicular are lower pitched, or they're going to be across the lung surface, like the majority of the lungs, the vesicular. Adventitious means bad. We got crackles or rails, a small rattling, clicking, bubbling, usually heard on inspiration, and you can describe crackles as being moist, dry, or coarse. Those of you with long hair can rub hair in front of your ear, and that's what a crackle is going to hear like when you listen to long sounds that have crackles.
Are you looking at the trach one?
Say that again?
Is it the regular spot?
That would be bronchial.
Oh,
Yeah, here, and here will be bronchial, right where the end of the trachea is and then when the bronchial tree starts. Wheezes, higher pitched, produced by narrow airways. Sometimes they can be heard audibly, like, I just think of a little kid with asthma that has wheezes. You can hear that audibly, you don't have to put the stethoscope to the chest. Bronchi is like the snoring. It's when airflow is blocked or almost blocked in the larger airways. And a pleural friction rub sounds like when you first walk on fresh snow, like that squishing sound when you crack through that nice first layer of fresh snow. That's what you're going to hear. That's what a pleural friction rub sounds like. It's grating, creaky, heard on inspiration and expiration. It's when the pleural layer of the lungs is inflamed and has that rubbing sound. If you were to hear any of the four adventitious sounds when you're assessing somebody, you might want to ask them to cough and deep breathe, because maybe that will clear. And if it clears to clear breath sounds, you'd want to document the clear breath sounds. You can document wheezes, clears with cough. There's a bunch of different ways you can document it. So if you're writing a narrative note, if you're documenting in the computer, you want to qualify what you're hearing and say that it does clear with cough. If it doesn't clear with cough, then that's a problem. We need to clear it somehow.
Is this gonna be on the test, or is this just refreshing us from what we already
I wondered that myself, and since it's counted as the hours of lecture, it will be a couple questions on the test.
Okay. So we can pull out our old respiratory thing.
You could, because that's from the fundamentals book. This is verbatim from the MedSurg book. So the questions I can guess would be related to nursing interventions about these things. And once I look at the old test and see what kind of questions they used, I'd make it part of the review for you guys, to be more particular. So there's a bunch of diagnostics, ABGs. I'll review there. You're asked to review a 63-year-old female who was admitted with shortness of breath. On your arrival, the patient appears drowsy and is on 10 liters of oxygen via a mask. You perform an ABG and get these results. Oops. You have this, right? I don't do this. So what are we looking at here? So the PaO2 is that, what does that indicate?
What'd you say?
The oxygen per.
Which one?
Patients in respiratory distress.
No. pH and then what else?
So bitter.
I totally forget.
The pH reveals what? Alkalosis or acidosis?
Acidosis.
Acidosis. How about the CO2? It's elevated. Probably the cause of the acidosis. So are we looking at respiratory acidosis?
Yeah.
Okay. And the patient's hypercapnia, what does that mean? That the CO2 is increased. And what would some symptoms besides the shortness of breath would indicate hypercapnia?
What is hypercapnia?
Elevated, CO2.
So what kind of
Yeah,
confusion?
definitely
Yes,
confusion, yeah.
confusion. Decreased consciousness level. Bounding pulse. So your patient was ordered ABGs. What can you tell the patient about ABGs?
They hurt.
They hurt. So it doesn't tickle when they're going for an artery. They go in pretty much at a 45 to 90 degree angle, directly in with a very small needle, like probably an insulin sized needle, like gauge, a 28 to 930 gauge needle. You don't have to go into explaining what each of the pH, the PaO2 and all, you don't have to go into that depth, but just that it's gonna monitor the respiratory status to see. Typically, somebody who needs ABGs are gonna be on the critical care unit, or heading there, pending the results of the ABGs, because they might have had a decline in the ER or on the med-surg unit. Pulse ox. So less than what percent is hypoxemia? 95. Starts to indicate hypoxemia. What might give you an inaccurate reading?
Nail polish.
Cold hands, nail polish, especially metallic nail polishes. What else? Artificial nails. Crappy circulation. Pulse oxes are only accurate if the pulse is accurate, so the pulse oximeter is going to give you the person's pulse rate and also the percentage of hemoglobin in the blood. So if the pulse is off, the pulse ox might not be accurate because the person's hemoglobin might be low, the person's hand might be cold. The small beam of light is actually on both sides of that probe, and it's calculating the amount of hemoglobin in the capillaries. Okay, you can do it on a toe, finger, earlobe. You can't put this on earlobe. It has to be a little special sticky thing. Patient has a continuous pulse ox on, which would indicate an inaccurate reading. Hey, core body temp is 95. You're not going to get an accurate reading. Too cold. Capnography and capnometry. Nice little, it's like a nasal cannula with this little disc on the end that actually is reading your inhalation and exhalation. Usually in an ICU setting or in the OR, the only time you'll see it outside of those settings is probably with somebody on a PCA pump, because we don't want their respirations to go below 12, and it'll set to alarm a PCA pump if they go below 12. If they don't set the alarm for it, so if that's below normal is 12. So capnography is going to give you a written tracing of the PaCO2, okay? And the capnometry, which is pretty much what you're going to get with the PCA pumps, it's not going to give you the written tracing. They're used synonymously, these two words. Sputum analysis, or sputum sample. So you have thick and sticky, which is sputum. You'll see people try to, pass off just their saliva in a sputum sample. So it's not, you're gonna get thick and sticky unless it's not sputum, it's not coming from deep. That is the, collection on the right there. That little test tube looking thing is actually inside the brown colored tube. And then you would remove the inside and send that to the lab. Name, date of birth, or the medical record sticker that's in their chart. Anything that goes down to the lab that's not labeled, they will not do anything with it. They will not spin it, they will not, test it. They won't get it back to you either, so you have to get another sample. It's just, cause how do you remember who you sent it on? If you sent sputums for 3 people, you know what I mean, that shift. So for a sputum analysis, take a few deep breaths, and you actually want to tell the patient to feel their deep breaths in their stomach. So you want them to hold their stomach and take the deep breaths. A few deep breaths. You want them to rinse their mouth out with water and spit it out. And then you want them to do that coughing and deep breathing with that huff, you know? Breathe in and then and you want them to expectorate from deep, okay, if they can. And then you're going to expectorate the sputum into the container. That's the only way you're going to get sputum and not saliva. Pulmonary function tests, there's 3 different ones, and the book really didn't go into specifics, but pulmonary function tests in general tell how well a patient moves air in and out of their lungs, and how well oxygen is entering the body. 3 types, we have spirometry, which is very similar to the incentive spirometer that we teach them to do individually. We got diffusion studies, and we got body plasmamography, it's called, and I'll spell that for you when we get to it. Spirometry is how much air you can breathe in, and how much you can quickly blow out, is what spirometry is, and that's a good picture of this spirometry. It's actually hooked up to the machine, and it'll get the different waves of how strong that exhalation breath is. Diffusion studies show how the lungs are processing the air. How well is O2 and CO2 exchanged or transferred between the lungs and the blood, is what a diffusion study is. And then the last one, I'm going to spell it, PLETHYS, MOGRAPHY, plasmaphysiography, body plasmaphysiography. How much air is in your lungs after you take a deep breath, and the amount of air that stays in your lungs after that deep breath is what that shows.
Is that the same as a residual volume?
Yeah. Yes, how much air is in the lungs after you take a deep breath, and how much is left after you exhale as much as you can. So you're like forcefully exhaling, and it wants to see how much air is left. And sometimes you just have that dead space air.
What was the other one you said? It was spirometry, the one you just spelled out, and then there was one on
Diffusion studies.
diffusion stuff. Thanks.
And respiratory therapists are the ones that are administering these studies. Bronchoscope or bronchoscopy gets up close and personal to the innards. It's the inner view of the lungs, a light and a small camera, and sometimes something to take a biopsy, like to pick at, like a mass, or to pick at the tissue. But it gets up close and personal, with the trachea and the bronchi. It might get a little bit into the bronchioles, but it doesn't go into the lung fields typically. Usually fiber optic. You can get tissue samples of what you're looking at. But so that thing that's pointing to the cancer right there, I'm not really sure that a bronchoscope could get at that, because it looks like it's at the very end of a bronchiole. So I'm not sure whether that's on the picture or not. Fluorescentesis shows an inner view here. The patient leans over a little bit. Needle is inserted into the pleural space between the lungs and the chest wall. Why would we do a fluorescentesis?
Collapsed lung.
Collapse lung or to remove fluid.
And this only goes into the pleura, or does it go into the lung itself?
No, it goes into the
Usually
pleural
just the
cavity.
pleura. Like a risk after this might be something called an empyema, like a pus-filled area that, because of the inflammation that, or infection that might happen because of the procedure itself.
It smells.
What,
It does.
yeah,
Really
because it's
bad.
usually indicating something is awry, yeah.
It smells really bad.
I'm just thinking, because like body fluids in general don't smell, you know, you have a wound, it's draining, you know, it might be old blood that smells, or an infection that smells, but body fluids typically don't smell. But usually this is gonna indicate something's going awry, so it's gonna have an odor to it, you're right.
When I was in the ED, we had to do several of those. Patients come in with either a collapsed lung or
Yeah, they're
Fluid.
awake.
Yeah.
They might give them a local anesthetic, but,
Do they x-ray this?
say that again?
Do they x-ray, how do they know they're getting into the pleura or not until they get anything else?
they know.
Yeah, it's I guess the feel of it, because it's not under fluoroscopy or anything, it's just,
Mm-hmm.
I hate to say blind, but it's not blind either, it's just knowing the anatomy, I guess, and not going that far.
Yeah, nurse won't do this. This was only by a physician.
But yeah, physician would do this, so a thoracic surgeon typically. I mean, I guess you'd have, ER docs, residents do it.
They can do ultrasound. Ultrasound will see that, the fluid.
Have a couple different biopsies. You can actually have the bronchoscoping and get the biopsy that way. You can have a biopsy needle like the guy laying down on the left, and go right into the lung field to get a biopsy. Now the needle, you go between the ribs, can have patients going to be sedated. This would be with CAT scan or fluoroscopy, so you can see what they're doing. Sample gets sent to the lab. Complications, you can get pneumonia, you can get an infection afterwards. Pneumothorax, you can collapse the lung. Get a sample of the lung tissue. They have something called VATS, video assisted thoracoscopic surgery. So it's in the OR under general anesthesia. Tell me a story when just take it easy. It's just, you know, they're not gonna be running a marathon. They're just gonna deliver that today. And then at that 12-hour point, they want you to get up and move, because just having stasis is not good either, so. very short time.
That's just like pretty much review. So what do we do, is there any more restoration, or is it? Okay.
Tuesday is pre-op, so I'll probably get pre-op and intra-op done on Tuesday. And then
Thank doggy. You gonna upload that?
Yeah, it's easy, man.
You got it figured out, it was just your card, right?
Oh, yeah. Like a piece of shit.
That sucks.
It is what it is.
Oh, well, no, I'll over some.
I can thank God. I hope I pass this, man.
What, this one?
The mental health one.
I mean, you got it. Plus, these were the two, like, lowest percentage wise.
Yeah, but still, man. I'm not working my ass off just to try to barely, just to, whatever.